Good morning, my student. How are you? Hope you all are ready and excited for today's class. Today we will be discussing about the largest part of diencephalon which control most of our sensation, which is the thalamus. So, let's see our learning objectives for today's class. First, we will discuss the structure of the thalamus, its location, function, and the blood supply. Second, the nucleus of the thalamus and their functions. Third, we will see the sign and symptoms if there is any lesions to the thalamus. And lastly, we will present some clinical cases for a better understanding of the topic. And to make the session more interactive, I use the help of 4 of your colleagues to present the topic with me. Thalamus is bird structure of large ovoid mass of a gray matter located deep in the forebrain, and it is the largest part of diencephalon. It is superior to the midbrain and it has many nerve fibers projected out to the cerebral cortex in all the directions. The thalamus has 2 ends, the anterior and posterior pole, and 4 surfaces, medial, lateral, superior, and inferior. The medial surface of the thalamus constitutes the upper part of the lateral wall of the third ventricle and connected to the corresponding surface of the opposite thalamus by a flattened gray band called interthalamic adhesion. The inferior surface is continuous with the tegmentum of the midbrain. There are some areas of white matter in the thalamus, including the stratum zonale that cover the dorsal surface, external and internal medullary lamina. The external lamina cover the lateral surface, while the internal lamina divided the nuclei into anterior, medial, and lateral groups. The thalamus has numerous connections to many parts of the brain, so it has several different functions, including sensory functions, as it is the relay station for all sensory information except olfaction; motor function, because it connects cerebral cortex with basal ganglia and cerebellum; emotion and memory, as it is connected to the limbic system, and also it contributes in sleep and awake cycle. The blood supply to the thalamus is derived from the branches of the posterior cerebral artery. These branches include polar artery, paramedian arteries, infralateral arteries, and posterior choroidal arteries. Thalamus is divided by the internal medullary lamina into anterior, medial, and lateral parts. The anterior part contains anterior thalamic nuclei, while the medial part contains the dorsomedial nucleus. The nuclei of the lateral part are divided into dorsal tier and the ventral tier. The dorsal tier include lateral dorsal nucleus, lateral posterior nucleus, and the pulvinar. Ventral tier include ventral anterior nucleus, ventral lateral nucleus, and ventral posterior nucleus, which is further divided into ventral posteromedial and ventral posterolateral nuclei. There are other nuclei of the thalamus, including interlaminar nuclei, middle line nuclei, reticular nuclei, and medial and lateral geniculate body. And now I will ask Abdel Khaliq to explain their connection and function.
Now we will talk about thalamic nuclei functions, and we'll start with the anterior thalamic nuclei, which is the fibers from a thalamic tract, cingulate gyrus and hypothalamus, and send fibers to cingulate gyrus and hypothalamus. Their functions are expression of emotions, learning, and memory. The next one is dorsomedial nucleus, which is the fibers from prefrontal cortex, hypothalamus, and other thalamic nuclei, and send fibers to prefrontal cortex, hypothalamus, and other thalamic nuclei. Its function is integration of somatic, visual, and olfactory information and relation to emotional feelings and subjective states. The next group of nuclei are lateral dorsal, lateral posterior, and pulvinar. They receive fibers from cerebral cortex and other thalamic nuclei and send fibers to cerebral cortex and other thalamic nuclei. Their functions are unknown. The next one is ventral anterior nucleus, which is the fibers from reticular formation, substantia nigra, corpus striatum, premotor cortex, and other thalamic nuclei, and send fibers to reticular formation, substantia nigra, corpus striatum, premotor cortex, and other thalamic nuclei. Its function is influences activity of motor cortex. The next nucleus is ventral lateral nucleus, which is same as the previous one, but also major input from cerebellum and minor input from mid nucleus. Its function is influences motor activity of motor cortex. The next one is ventral posterior medial nucleus, which will see fibers from trigeminal lemniscus and gustatory fibers, and send fibers to primary somatic sensory cortex, and its function is relays common sensations to consciousness. The next one is ventral posterior lateral nucleus, which is the fibers from median and spinal lemnisci, and send fibers to primary somatic sensory cortex. Its function is relays common sensations to consciousness. The next one is interlaminar nucleus, which is the fibers from reticular formation, spinothalamic and trigeminothalamic tracts, and send fibers to cerebral cortex via other thalamic nuclei and to corpus striatum. Its function is influences levels of consciousness and alertness. The next one is midline nucleus, which is the fibers from reticular formation, but the efferent fibers are unknown and the function unknown as well. The next one is reticular nucleus, which is the fibers from cerebral cortex and reticular formation, and send fibers to other thalamic nuclei. Its function is integrates and controls thalamic activity. The next one is medial geniculate body. It receives fibers from inferior colliculus, lateral lemniscus, from both ears but predominantly the contralateral ear, and send fibers to superior temporal gyrus. Its function is hearing. The next one is lateral geniculate body. It receives fibers from optic tract and send fibers to visual cortex of occipital lobe. Its function is visual information from opposite field of vision. It's important to mention that every thalamic nucleus except the reticular nucleus sends axons to specific parts of the cerebral cortex, and every part of the cerebral cortex sends reciprocal fibers back to thalamic nuclei. This would indicate that information received by the thalamus is always shared with the cerebral cortex, and that the cortex and thalamus can modify each other's activities. The next thing is that the thalamus is an important relay station for two sensory motor axonal loops involving the cerebellum and the basal nuclei. The first loop is the cerebellar rubro-thalamic cortical pontocerebellar loop, and the next one is corticostriatal pallidal thalamic cortical loop, both of which are necessary for normal voluntary movement.
Thank you, Abdul Khaliq. And now let's see what Razan and Maryam prepare for us about the thalamic lesions.
There are two considerations that must be taken into account when attempting to diagnose lesions of the thalamus. First, thalamic nuclei are small, so the lesion producing highly specific effects are uncommon, although they do occur. Second, the thalamus is immediately bounded by the internal capsule and is in close proximity to the deep motor nuclei of the cerebral hemisphere, putamen, caudate, and globus pallidus, so that thalamic lesions frequently are accompanied by symptoms from damage to these other structures. However, thalamus can be invaded by metabolic disorders, trauma, tumors, infection, and vascular disease. Since small branches of the posterior cerebral artery supply much of the thalamus but not adjacent structures, selective thalamic lesions do occur. Occlusion of these small branches results in a number of symptoms characteristic of the thalamic syndrome. The lesion could be unilateral or bilateral, and the symptoms varies depend on the location. First of all, we will talk about sensory loss. These lesions usually result from thrombosis or hemorrhage of one of the arteries that supply the thalamus. If the damage includes ventral posterolateral and ventral posteriomedial, a contralateral hemianesthesia usually results. Since the thalamus receives sensory impulses from the opposite side of the body, the disability resulting from lesions within it will be confined to the contralateral side of the body. Typically, all somatic sensory modalities are affected: light touch, conscious proprioception, two-point discrimination, vibration, pain, and temperature. This loss of all somatic sensory modalities is an important diagnostic sign for thalamic damage. Lesions of the internal capsule or cortex that impair somatic sensory function typically affect different modalities to different extents, often leaving pain sensation unchanged. And now I will leave you with Mariam to complete the rest of thalamic lesions.
Thalamic pain is severe and treatment-resistant type of central pain that may develop soon after the thalamic lesion or may only gradually evolve after weeks to months following the episode. It's an exaggerated, unpleasant, or painful sensation resulting from mild cutaneous stimulation called hyperalgesia, or in some cases, cause algia, a spontaneous pain with no apparent stimulation can occur. These symptoms can be made worse during periods of emotional distress. The quality of the pain sensation varies, being described as burning or turning, but nearly always as very distressing, often lasting well beyond the stimulation that evoked it. The thalamic pain occurs on the opposite side of body. Abnormal involuntary movement. If the damage extends into ventral anterior and ventral lateral nuclei, complex movement disorders can result. The movement disorders can be as cerebellum damage disorders, ataxia, which may present with symptoms of an inability to coordinate, balance, gait, extremity, and eye movement, and intenser tremor is a tremor that becomes obvious and often exaggerated as the need for precise movement increases. There is oscillation of increasing amplitude during voluntary movement, especially as the movement draws to its conclusion. Or it may be as basal ganglia damage disorder, chorioathetoid movement. Is movement disorder that causes involuntary twitching. It is a serious condition that affects posture, walking ability, and everyday movement. This reflects that both cerebellum and basal ganglia project to ventral anterior and ventral lateral nuclei. All such problems occur contralateral to the side of lesion. Thalamic hand. In some patients with thalamic lesions, wrist of contralateral hand is pronated and flexed. The metacarpopharyngeal joint are flexed, and the interpharyngeal joint are extended. The finger can be moved actively, but the movements are slow. The condition is due to altered muscle tone in the different muscle groups. Treatment of the thalamic lesion: antidepressant, convulsants, and opioid analgesics, physical therapy, deep brain stimulation, desensitization of tactile stimuli. Now we will shift to my colleague Ayat to see a real case of thalamic hand.
We have here a case of 60 years old man represented with thalamic hand. He was admitted with complaints of weakness of right upper and lower limb, accompanied by dystonia of the hand, burning pain, and dense sensory loss. And this combination of findings is consistent with thalamic hand, where the hand is pronated and flexed, metacarpopharyngeal joint are flexed, and interphalangeal joint are extended. After taking MRI for this patient, they found that this is possibly due to the left thalamic bleed. The right-sided hemianesthesia and the burning pain in the right hand are referred to clinically as the thalamic syndrome. and are due to occlusion of one of the central branches of the left posterior cerebral artery that supply the sensory nuclei of the left thalamus. The hemiparesis, which is the weakness of right and lower limb, could be explained by a temporary occlusion of a branch of the left posterior cerebral artery to the left cerebral peduncle. Another one with same symptoms with same thalamic hand, also in his right hand, but due to a mass in his left thalamus. But after fluid steroid therapy, he shows significant improvement, and here the doctor do a test called nose finger test. That is, touch your nose with your index finger and then reach out and touch my finger. So the examiner looks for evidence of intention tremor or dysmetria. Dysmetria is evidenced by difficulty in controlling the range of movement. So finally, there is of course a lot of cases due to thalamic lesion, but we found that most of them lead to thalamic hand. We have here a 34-year-old woman who was admitted to the neurology department after complaining of gait instability for 20 years and seizure attack for 6 years. At age 14, she began experiencing slurred speech and unsteady gait. Meanwhile, she had learning difficulties and her academic performance was poor. At age 28, she developed recurrent generalized tonic-clonic seizure and myoclonus. She developed choroarthritosis at age 29. In the following years, the seizure and choroarthritosis progressively worsened. 2 years later, she could no longer walk independently due to postural instability caused by ataxic gait. Medical, birth, and family histories were non-contributory. No other family members were known to be affected. So from this case, it seems that all of these symptoms, slurred speech because of ataxia of the muscle of the larynx, unsteady gait, ataxia gait, and other symptoms due to paralysis of different body muscles that caused by blocking of the corticospinal fibers by edema due to thrombosis in the central branches of the posterior cerebral artery which supply the thalamus. And we see in this video that both sides of her body are affected, so we can say that both posterior cerebral artery get thrombosis or occlusion. And for the choroarthrotoid movement of the limbs were probably due to damage of to both sides of thalamus or the dentothalamic nerve fibers.
Thank you all for your participation and hope you enjoy our today's session.